In Part B of Chapter 14, we're going to talk about the spread of disease. We're going to look at where we find disease and how we actually spread it, whether it be from person to person, animals, or non-living reservoirs. So we first need to define reservoirs of infection. Reservoirs of infection are continual sources of infection. We have some diseases where humans are the only reservoir. Things like AIDS and gonorrhea are examples of human-only pathogens. We also can talk about carriers in the human reservoirs. So when we looked at our stages of disease, we said that people could potentially be infectious in the convalescence phase. Carriers have inapparent infection or latent disease, but can still spread it to others. The classic example was Typhoid Mary. Typhoid Mary was harboring the causative agent of typhoid fever, the Salmonella typhi, in her gallbladder. She was one of the first identified carriers in the United States of the disease, and because she was a cook to the rich and famous, she was actually spreading the disease. She infected more than 50 individuals, and 3 of those actually died. So the public health agencies were tracking Mary, and they said that she could no longer be a cook. She couldn't understand that she couldn't be a cook and refused to actually not do her chosen profession. So they didn't incarcerate her, but she was put in forced quarantine. She actually died in forced quarantine, still not believing that she was the cause for all these other people getting typhoid fever. So it was a classic example of looking at the right for people to enforce quarantine and what are people's personal freedoms. We're tackling with that much in a different way, but kind of the same principle today with COVID-19. Also with COVID-19, we see the animal reservoirs. So some of the classic examples are things like rabies and Lyme's disease. These are zoonotic diseases where we see that the organism, whether it be bacteria or virus, whatever, gets transmitted to humans. We also have non-living reservoirs, soil, food, water. So when you talk about things like botulism and tetanus, cholera, typhoid fever, these are coming from these non-living sources. So again, we're talking about Typhoid Mary as a carrier of the disease. However, the problem was the fecal-oral transmission. The organism was getting in through the non-living reservoir, the food in this case, and because Mary was a cook, that was the problem. So not to know all of these, but just to provide some examples of selected viral zoonotic diseases. When we talk about influenza, we said that the reservoirs are things like pigs and waterfowl. We've also seen in things like hantavirus. These are found primarily in rodents, and that means that when we come in contact with their urine, saliva, or feces, we can become infected. Selected bacterial zoonoses, we see things like the plague from Yersinia pestis. We get it from a flea bite. However, the problem is the reservoir that harbors the disease, the rodents. Things like Lyme's disease, it is field mice and deer that are the reservoir, even though we get the disease from a tick bite. Rocky Mountain spotted fever is another example of a tick-borne disease, and the major reservoir are rodents that are out in the environment. There are also selected eukaryotic zoonotic diseases. Malaria is the classic example. Even though we talked about the life cycle of us being the intermediate host for the parasite, the Plasmodium, we are not the only intermediate host. So the main reservoir is actually monkeys that are also being fed on by the Anopheles mosquito. Things like our tapeworms, pigs for the Teniosolium tapeworm from pork. So these are classic example of eukaryotic pathogens that are from zoonotic sources. When we talk about the transmission of disease, we can think of it as things that we come in contact with. Direct contact requires close association between an infected person and a susceptible host. So that's why we are currently practicing our social isolation to prevent any of that direct contact. But we can also talk about it from droplet transmission as well. We're learning a lot from our experience with COVID-19. When we talk about transmission from droplets, these are biological droplets that we put out as airborne droplets that are less than a meter, that are things that are sputum in our saliva as we cough and sneeze. We can also have indirect, which is spread by fomites. These are inanimate objects, so my pen can be a fomite, a tissue can be a fomite. Anything that we touch where we may have deposited those agents, those infectious agents, those can potentially become fomites. So droplet transmission has been very interesting to try to figure out for the coronavirus, and very important. When we look at these spread in general, we start with an infected individual, and they can be coughing, sneezing, but there can be other ways that you can have those droplets getting out in the environment. Most of those are going to travel less than a meter, and so you have to be very close, kind of that direct hit, in order to get things from droplet transmission. However, we see there's also some airborne transmission that can be greater than the 1 meter, and that's much smaller particles that can still carry infectious agents. With the droplets, they can also get on hands and objects and things, so that way we can also see that direct contact and indirect contact contributing to the disease in susceptible individuals. In looking at the COVID-19 coronavirus and how far does it travel, we're not exactly sure. But when we look at that slow motion photography of what happens when you are coughing and sneezing, we see that the large infectious droplets only are about 1 to 3 feet at most. Even the small infectious droplets are under 5 feet. So that's why we have this 6 feet limit of what we're trying to use for social distancing. There may be potential infectious nuclei, but we're not quite sure. But we don't think that beyond that 6 feet that it is a problem for the coronavirus, but still under investigation. There's other ways that we transmit disease as well. So vehicle transmission is becoming very important from the standpoint of our food. There are many emerging foodborne illnesses in the United States. That's because we no longer prepare all of our food. So anytime you go to Wawa or a restaurant or eat from the food trucks, there's always the potential for vehicle transmission. So everything that the hospital is like the perfect storm. We estimate that 5 to 15% of all hospital patients acquire a nosocomial infection. Why? Well, people are in the hospital because they're sick or having surgery. That makes them compromised. So we have a number of compromised hosts. Because people are in the hospital and are sick, there's a whole plethora of microorganisms in that hospital environment. You add to that the chain of transmission by healthcare professionals and staff, it makes the perfect storm for nosocomial infections. Nosocomial infections are the 8th leading cause of death. So taking very seriously these types of infections that are acquired as a result of a hospital stay is important. What type of microorganisms are in the hospitals? Well, in the 1940s to 50s, most of the problem was really the gram-positive microbes, so things like our Staph aureus. In the 70s, we started to see problems with the gram-negative rods, E. coli and our Pseudomonas aeruginosa. The 80s, resistant Staph aureus, and not only the resistant Staph aureus, things like the MRSAs that we'll talk about in a moment, even the coagulase negative, so things like our Staph epis were becoming problematic, and the enterococci started to make their emergence on the scene. In the 1990s, kind of an even split between gram-positives and gram-negatives, but the real story for starting in the 20,000 is concern for antibiotic resistance. Relative frequency of nosocomial infections varies according to what might be the potential source of infection. So we see the most common thing for nosocomial infections are UTI, urinary tract infections. The 3 different numbers on the pie chart here are from the 3 different editions of the book. So we see urinary tract infections have been hovering anywhere between 32% to 40%. So they're quite common because people often have to be catheterized for surgeries or other procedures. This is followed with surgical site infections, anywhere from 17 to 22%. Again, this makes sense. You're giving opportunity for organisms to get into those surgical sites, and once they do, causing infection is then much easier. Followed next by respiratory infections. Somewhere between 13 to 15% of all nosocomial infections are lower respiratory. In the hospital, people are often lying down in that prone position, so they're just not getting all of that tidal volume moving things up and out. And anesthesia causes things to go to sleep. That includes your respiratory system. That's why the respiratory therapist comes around and makes you do those respiratory exercises to try to get everything moving again, up and out. We see bacteremia caused primarily by IVs has been anywhere from 14%, dropped down to 6% for a while, and now up to about 14%. Again, we try to make sure that we are doing good practices, but when you have so many IVs being inserted, it's just a continual source of potential infection. The last category is just the other, but can include skin infections. So anywhere from 11 to 22%, currently about 17% of all hospital infections. These can also include newborns that can get a variety of cutaneous infections. Again, we talked about the fact they are picking up some of their normal flora as they first pass through the vagina. However, they're now exposed to the world, the environment, and all the people around them. And so they start to pick up their flora, but not all the time is it good flora. Sometimes they could potentially pick up things that are pathogens and can cause cutaneous infections. As I said, the real issue has been with antibiotic resistance. The World Health Organization around 2014 really started sounding the alarm on superbugs. These are infections that are going to basically be virtually untreatable. The problem is so serious that it threatens the achievement of modern medicine in their estimation. They are concerned that we're going to end up having a post-antibiotic era in which common infections from minor injuries can actually result in lethality just because we're not going to be able to treat what were once simple infections because we're seeing so much antibiotic resistance. When we look at the common causes of nosocomial infections and look at the percentage of resistance, we see some alarming trends. The gram-positive cocci can be anywhere to 28 to 87% antibiotic resistant. When we look specifically at the coagulase-negative staphylococci, things like the staph epi, they can get into a surgical site infection and cause sepsis. Some of these are up to 89% resistant to antibiotics. We have heard a lot about the Staph aureus. 60% of them may be antibiotic resistant. So we see that the variation in these organisms causing the nosocomial infections, but the bigger story is probably the percent resistance. The gram-negative rods, they are behind the gram-positives, but we're still seeing alarming trends of increases in things like E. coli, which account for about 23% of all nosocomial infections. Anywhere between 5 up to 32% of the organisms are resistant. Nearly half of all nosocomial diarrheas are actually caused by Clostridium difficile, or C. diff. We see that people on antibiotics, normal flora in the gut is going to be diminished, and the C. diff has the ability to then expand and cause the infection. We also see fungi. Lower percentage, but Candida albicans is often the causative agent there, but simple UTIs and surgical infections, occasionally sepsis. So it's not a large part of the nosocomial story of infections, but still significant. What has been on our radar has been the MRSAs, the methicillin-resistant Staph aureus. When things became penicillin resistant, we started to look for these others. Methicillin was great when it first came out, but then starting in the 60s, we started to see the methicillin-resistant Staph aureus. For a while, they weren't really increasing, but starting in the 80s and definitely in the early 1990s, we started to see major emergence of methicillin-resistant Staph aureus. We have also seen that there's different strains, so to speak. There is the USA 300, which accounts for about 89% of what are community-acquired strains. So that means that these MRSAs are just out there in the community, in daycare centers and in schools, not just in healthcare settings. In healthcare settings, 92% of those strains are what are USA 100. So it's the emergence of slightly different varieties of these strains, but still problematic. We are also starting to experience the vancomycin-resistant strains, or the VRSAs. We have only had 14 of these VRSAs in the United States so far. However, this is problematic because vancomycin is considered to be the last line of defense. If we can no longer treat, then we're going to have a major problem with the number of Staph aureus that are out there. We see more than a handful of what are the VISAs, the intermediate resistant vancomycins, but again, these are starting to emerge. How do we control nosocomial infections? Some of the answers are simple. Wash your hands. The CDC reported that only 40% of the time were healthcare professionals washing their hands before patient interaction. Now, this has become easier. Once upon a time in older hospitals, you had to go into the patient's bathroom to wash your hands or go to the nursing station. New hospitals now have hand washing stations as soon as you walk in the door, as well as usually hand sanitizers. So these are helping control nosocomial infections. More use of single-use sterile instruments, so you don't have problems of did something get sterilized properly. just improved disinfection criteria in general. Hospital infection control committees monitor process and procedure to make sure that we are doing the best practices to limit infection. We are also trying to monitor the use of immunosuppressive drugs. This makes people more susceptible, and this is going to lead to the number of nosocomial infections overall. And trying to prescribe antibiotics only when necessary. So recognizing that we really don't want to overprescribe, we need to make sure that we are using our antibiotics only when needed. So we want to talk about how we reduce these nosocomial infections. Everything helps, whether it be personal contact, limiting that, improvements in any type of cleaning procedure, controlling the products that people come in contact with, monitoring disease throughout the hospital. All these things are going to help us prevent the spread of nosocomial infections. But besides things like nosocomial infections, we see a variety of emerging infectious diseases. This little picture is from the 2015 World Health Organization. They get together each year and try to anticipate the emerging diseases that are coming out of, whether it be the zoonotic diseases or changes due to climate change. All of these are predictors of what might be the next disease epidemic. For emerging infectious diseases, these are relatively new or increasing in incidence. They show the potential to increase in the near future, and that's why we have things like a novel coronavirus emerging. Contributing factors, what we're seeing with the coronavirus is true of other strains. So we had the emergence of a nasty strain of Vibrio cholerae, the O139, becoming more problematic. Used to be, E. coli was just normal fecal flora. Then we saw the emergence of the enterohemorrhagic pathogenic strain found in hamburgers and such, the O157H7. Our emerging strains of H1N1 of the flu. All these things are new strains that are now causing disease because people do not have prior immunity. As we said, inappropriate use of antibiotics and pesticides. So we're developing antibiotic-resistant strains, and if we have resistant to pesticides, that allows some of the vectors to survive that could also transmit these emerging diseases. Changes in the weather, global warming. If we allow populations of mosquitoes to expand, we're going to see a lot of mosquito-borne diseases, things like malaria, yellow fever, dengue fever. The hantavirus is a rodent reservoir, but as the rodents are able to inhabit more warm areas, they are going to spread disease along with many of the arthropods. As I said, the coronavirus was on our radar. There was an article, this is from Nature Reviews in 2015, where they started looking at the emerging infectious diseases, looking at the host pathogen interactions. At that time, they noticed the potential for the coronaviruses. They can infect a wide variety of species. Bats have been the problem recently, but bats, birds, cats, dogs, pigs, mice, horses, whales, and humans. So the MERS and SARS were just the first, but that should have been the warning. People were, I think, complacent because the SARS kind of came and went, and MERS, although highly infectious, never really took hold. And so people knew the coronaviruses were out there, but just didn't anticipate it enough to predict what COVID-19 was going to do. So modern transportation as well contributes to emerging infections. We see every spring we have to monitor in Philadelphia for West Nile virus. It's not naturally found, but because of things that have been transported from abroad, we now see various new emerging infections. Anytime you have war, disaster, or humans just expanding where they are cutting down forest, we see emerging diseases. Out in California in 1994, one of the larger earthquakes saw an increase in one of the fungal pathogens, the coccidioidomycosis. In South America, cutting down the rainforests are making the emergence of hemorrhagic fevers, lots of viruses that we haven't been exposed to and have no immunity. Animal control. We know that the proliferation of our deer population means that Lyme disease has become prevalent on the East Coast, and also public health failure. We didn't realize with diphtheria that similar to tetanus, we needed a booster. So we saw an emergence of diphtheria because people were no longer immune. We assumed that because they had been vaccinated, they had lifelong immunity, and that was just not the case. That's why you need to get boosters of your DTP. Not everything gives you lifelong immunity, and we have learned that some things, if we are not making the public aware of the need for boosters, we can start to see an emergence of those pathogens. So that's why we have not only places like the CDC, we also see in the news the National Institute of Allergy and Infectious Diseases, Dr. Fauci, and his important role in COVID-19. But his agency does a lot in trying to look for emerging diseases. So some of the ones that they have identified recently have been HIV, SARS, which instead of being SARS was the COVID-19, Lyme's disease, the E. coli 0157H7, hantavirus, dengue, West Nile, and Zika, things that you've heard about in the news. However, there's also re-emerging ones that we're concerned about. Malaria, TB, cholera, pertussis, which is whooping cough, influenza, pneumococcal diseases, and gonorrhea. So we are constantly having to look for what is emerging and things that are coming back. That is why we always have to track things. Epidemiology is more important than ever. Studying where and when diseases occur is important in understanding when they're going to reemerge or how they are going to act within a population. If we look at some examples here, on the left-hand side, the bottom looks at Lyme's disease by month in 2002. We see that the peak at that time was in October. In 2009, we see the peak now is more likely to be in July. So understanding when diseases are going to occur, especially if they're seasonal. Lyme's disease, though, overall, if we look at the top right graph, that is slowly increasing. And so understanding that this is something that is not only increasing in number, it seems to be spreading beyond just the East Coast. So we want to track. TB was very prominent in the 1930s and 40s, a very prolific killer. And we see now, even though we still have too many cases, it is at a lower background level, but it has the potential to be something that we feel we can eradicate. So that's why epidemiology is important. Things started with people like Florence Nightingale and John Snow. Florence Nightingale was a British nurse that during the Crimean War, she took meticulous records about the cause of illness and death during the war. And that was kind of the basis of how we do epidemiology. John Snow was the first known public health response to an epidemic. He noticed that cholera, which was fairly common in England at the time, but there was an outbreak in London, and most of the people that got sick seemed to center around a specific water pump, and he proposed that the cholera was coming from that water pump. He convinced people to close down that water pump, and the number of cases of cholera decreased. So he proposed breaking that fecal-oral transmission back in 1848, 1849, and again was one of the first known epidemiological responses. So if we look at the types of epidemiology, we see Snow was responsible for what is referred to as descriptive epidemiology. That's the collection and analysis of data regarding occurrence of disease. He specifically was looking at cholera, but it's generally retrospective. You see that cases are happening, and you try to then collect that information and analyze what's going on. Florence Nightingale, she was responsible in setting up that rules for what is referred to as analytical epidemiology. This is a comparison of a diseased group versus a healthy group. We can do this either as case-controlled method of truly comparing those that have the disease and those that don't, but we can also do cohort methods where we instead look at exposure versus non-exposure to try to figure out what might have been the cause. Much more controversial is epidemiology that is done experimentally. So we always want to do the study of controlled experiments, but sometimes that's just not always the case because epidemiology is what's going on in a population. We can't always control things. One of the worst cases on record was the Tuskegee experiments for syphilis. When the study started, syphilis did not have a treatment, and therefore the study started with good intent. However, in the beginning of the 1940s, syphilis was treatable. Penicillin was now available, and that was the effective treatment. The study should have been stopped at that time. However, people let the study go on, trying to understand the long-term effects of syphilis, and they were trying to do this in an experimental way. We now know that not only in a controlled experiment, but if you're doing these type of things, we have to have informed consent so that we don't have repeats of things like the Tuskegee experiment. Any health professional is responsible for doing case reporting. So healthcare workers need to report specific diseases to local, state, and national offices. That list comes from what is the Nationally Notifiable Disease List. Clinicians are required to report any occurrence of these diseases. This is an abbreviated list, but just to give you an idea, the CDC maintains this list on nationally notifiable infectious diseases. So you see things on there that probably make sense. Measles and mumps, the plague. Other things that maybe you wouldn't think, smallpox, even though we haven't seen a natural case of smallpox since 1977, we still maintain it on the list because obviously that would be reportable. Many of our sexually transmitted diseases are found on this list as well. So the Center for Disease Control maintains this list, and they're responsible for putting out the weekly morbidity and mortality reports. Morbidity is the incidence of a specific notifiable disease. Mortality is obviously the death from these notifiable diseases. That's why it's so important to gather this information. So anytime these diseases are seen, they have to be reported to the CDC. One of the things that I'd like to point out, we call the CDC the Center for Disease Control, but along the way, the designation of prevention was added. I want to just emphasize that the CDC is no longer just tracking. They're actually making public policy. They are putting out public health awareness, both for clinicians and the general public, in a way that wasn't part of their original mission. So they have become just the mecca of understanding epidemiology and making the public aware of problematic diseases and preventions and how to find cures and help. So they do a wonderful job within the United States. They obviously work closely with the World Health Organization as things go to a global scale. But in the United States, the CDC is the point for everything epidemiological. As always, make sure you check your understanding, and that's it for Chapter 14.